Well, thanks Manish for giving me this opportunity. So my job here is to talk about HRD. So Dr. Arun has already spoken about so many things in molecular oncology, and then I'm here to speak on the clinical aspect of HRD. Is it the new BRCA or is it something which is more than the BRCA? So to see the burden of ovarian cancer, we can see over here that almost close to 3 lakh patients, women, they are diagnosed with ovarian cancer every year. And this was the data of 2018. And out of these, 60% they were advanced disease, and 70% of these women, they will relapse within 3 years of first line treatment. And the 3 to 5 year, the 5 year survival of these patients with advanced disease is close to 30 to 50%. So definitely it is an unmet need, and we need to improve upon the treatment to improve the outcome. And this is the exact natural course of ovarian cancer. So it is characterized by relapses and remissions. And we can see over here that the subsequent relapses, the platinum free interval, which is the time period between the last dose of platinum and the first relapse. So this platinum free interval, so this keeps on decreasing in the subsequent relapses. And there will be a time when the disease will be platinum resistant or refractory. This is the resistant disease, and these are the refractory disease. So at some point of time, the patient will have some intestinal obstruction and will succumb to the disease. So once the disease relapses, it is largely incurable. First line treatment for advanced ovarian cancer is the optimal setting to achieve a potential cure. So these are the different timelines. So where there had been paradigm shift in the treatment of ovarian cancer. Till 2003, the only treatment which was there was the chemotherapy, non-platinum based chemotherapy in 2003. So there came the era of platinum taxane based therapy, and which became the standard of care. Till 2011, so the chemotherapy alone was the standard of care. 2011, bevacizumab was approved on the basis of GOG 218 trial, which showed a median PFS advantage of close to 6 months. And there was no overall survival advantage with the addition of bevacizumab. So this was the first paradigm shift. The second paradigm shift came in 2018 when FDA approved PARP inhibitor in the first line maintenance setting on the basis of SOLO-1 trial, so which had selected only the BRCA mutated patients. So here the benefit of olaparib, a PARP inhibitor, was given only to those with BRCA mutation positive status. In 2019, on the basis of Paula-1 trial, so all comers, they were given, they were tried with the addition of olaparib to the standard of care chemotherapy plus bevacizumab regime, and it had shown that those patients who were HRD positive, so they had definite benefit in terms of PFS with the olaparib addition. So this was the third paradigm shift. So we will discuss all these things. So what is the mechanism of DNA repair? So we can see over here these inserts may be radiation, chemotherapy, reactive oxygen species, replication errors. So these leads to single-stranded breaks, and these single-stranded breaks in a normal scenario, these are rectified with the help of base excision repair pathway, and later on the PARP inhibitor. So this is very, very essential for this base excision repair pathway. So those single-stranded breaks which does not get repaired with this single-stranded repair pathway, so these get converted into double-stranded breaks, and these are again repaired with the help of two kind of pathways. One is the error-free pathway, and one are the error-prone pathway. So the error-free pathway, so they are the homologous recombination pathway, and these are the genes which are important in this. These are BRCA1, BRCA2, RAD51, mRN complex, and ATM. And other two pathways, those are the non-homologous and joining pathway, NMMEJ. So these are the error-prone pathway. So the whole physiology is that the tumor cells which have this BRCA1 or 2 mutation status, so they are not able to repair these double-stranded breaks. So if these cells, they are made PARP deficient also, so then these single-stranded break coming out of chemotherapy, radiation, or some other insults, they will not be repaired with the PARP inhibitor, and later on they will not be repaired with the double-stranded break repair pathway. So this will ultimately lead to cell death, and this is called synthetic lethality. So this is the concept which we have to understand. So coming to the frequency of HRD positive patients. So this was a trial which showed that HRD positivity is seen in approximately 48% of the patients, and more than 50% of the patient, they have either HRD or possibly HRD. And another 15% of the patient, they do not have the status of HRD. So these are HRD unknown. And so these HRD positive patients, they have included BRCA mutation either as a germline or a somatic mutation. Then there are other homologous recombination repair gene mutations like CDK12, then core RAD, then FA gene mutations, then altered HRR gene expression like BRCA1 promoter methylation or RAD51 promoter methylation. And there are other unidentified causes. So in totality, more than 50% of the patients, they have HRD, which we can detect with the genomic instability score, and it leads to genomic instability. So coming to here, so these are four kind of cells we can come across. The normal cell, they have intact homologous recombination repair pathway as well as the base excision repair pathway, so which leads to cell survival. Either of BRCA like homologous recombination deficiency or base excision repair deficiency alone, so they will not lead to cell death. But whenever there is combination of homologous recombination and base excision repair defects, so then it can lead to cell death. So this is the concept we use those cells which are deficient in BRCA or HRD. So they are deficient with the homologous recombination repair. And if we see, if we give PARP inhibitor in these patients, which leads to defect in the base excision repair pathway also, which leads to cell death or tumor cell death. So there are two kind of tests which are available to identify HRD. So one set of tests, they focus on looking at the cause of HRD. So these are the HRR genes test, gene mutation test, or BRCA gene mutation test. What they do is that they focus on the genomic changes that can cause defects in HRR pathway, and they assess the cause of HRD by looking for the loss of mutation of these key HRR genes. So another way to look at HRD is to look for the effect of HRD, and this is something genomic instability test, which is on the basis of these three type of things. So one is loss of heterozygosity, one is telomeric allelic imbalance, and one is large scale state transition. And with these three aberrations, three kind of aberrations, a genomic instability score is defined. So which, if it is more than 42, so then it is HRD positive, and if it is less than 42, so it is HRD negative. So these are the two ways of looking at HRD. And there comes the importance of looking at HRD rather, so to look at the effect of HRD rather than to look at the cause of HRD. We can see over here that 15% of the patient, they have blood where they have germline BRCA mutations. If we see, if we include the somatic mutation also with this, so then the 20% is the number which will get benefit out of olaparib. If we do HRR mutation testing, so we are including germline and somatic BRCA along with other HRR mutation, so the number comes out to 31%. And if we see the HRD testing with genomic instability score, so close to 50%, they will get the benefit out of PARP inhibitor. So there is incremental benefit of using this test, and the best test to use and to give PARP inhibitors to is on the basis of HRD. So ESMO guidelines also recommend HRD testing to identify most patients who will gain benefit out of PARP inhibitor. And we can see over here that germline BRCA mutations. So in first line, it is a good thing to recommend. Then tumor BRCA mutation, good. Then somatic BRCA mutation, again, good is the criteria. And if we see the genomic instability score, again, it is a good parameter to use PARP inhibitor in first line maintenance setting. So these are the validated method to detect HRD. So one is the tumor BRCA mutation, presence of BRCA mutation that gives HRD positive status. And the other thing is the genomic instability with the, like the example of this is the myriad my choice genomic instability. And there are a lot of other assays which are available in Indian market right now. And you can use those also. And we have to see the, as pointed out by Dr. Arun, that we have to see the analytical validity of these assays also. And it is on the basis of these three kind of aberrations. So one is LOH, one is TAI, and one is the LSST. So these are these are the steps on the basis of which we will decide whether the patient is a candidate or not. So first step is to do a BRCA mutation status and HRD status, if whether it is a positive wild type or the mutated type. The step two is whether the patient is a candidate for bevacizumab or not. And the third is the clinical characteristics, platinum sensitivity beyond HRD status, because if the patient is not platinum sensitive, even if there is HRD positive status, then probably I'll not be very keen in using in the upfront setting. So coming to the clinical trial data of olaparib maintenance. So there are two trials, Solo 1 and Paula 1. So we have 4 or 5 PARP inhibitors which are being used in these settings. But as of now, the maximum approvals, so they are for olaparib, and the maximum data and maximum experience is also with the olaparib. So we can see over here that Solo 1 trial, they had selected newly diagnosed advanced ovarian cancer patient with any surgical outcome, and they had selected only BRCA mutation positive status patient. And these patients were either received surgery, upfront debulking surgery or interval debulking surgery. And those patients who had response to platinum-based chemotherapy, they were given olaparib maintenance. So the second trial was the Paula 1 trial, which was for the all comers. So they had not selected on the basis of the biomarkers, but they had pre-specified subset analysis on the basis of tumor BRCA mutation status, then HRD status. So they had done the pre-specified subset analysis. Here, the surgical outcome also did not differed. So either the patient had complete cytoreduction or incomplete cytoreduction. All were candidate for this trial. And in this trial, bevacizumab was used in all the patients. So coming to Solo 1 trial, they had selected newly diagnosed FIGO stage 3 or 4, high-grade serous or endometrioid ovarian PPC or fallopian tube cancer. They had selected the patient with germline or tumor somatic BRCA mutation positive status. And sorry, these patients were randomized into 2:1 fashion to olaparib vis-a-vis placebo. And the total duration of the treatment was 2 years. And if the patient was having benefit from the olaparib and patient was not having any toxicity, these patients could have been continued on olaparib till progression as per the PI discretion. So the primary endpoint of this trial was the investigator assessed PFS, and the secondary endpoints were PFS using BICR, then PFS2, then overall survival, then time from randomization to first subsequent therapy or death. And similarly, they had also looked at the time from randomization to second subsequent therapy or death. And they had also looked at the HRQOL on the basis of FACT-OTOI scores. So we can see over here, these are the Kaplan-Meier curves showing the PFS advantage. We can see over here, initially only the graph separated. And we can see over here that the median PFS was 56 months with the olaparib and 13.8 months with the placebo, with a hazard ratio of 0.33. And we can see over here at the time, 2 years was the time when olaparib was discontinued. Even after discontinuing, the benefit was persisting. And we can see over here that the graph remains separated throughout. At that 5-year follow-up, so 48% of the patients, they were still on olaparib as compared to 21% who were on placebo. So they also had looked at the PFS2 time to second subsequent treatment also. And what they had seen was that the hazard ratio was 0.46 in these two endpoints. And this was in favor of olaparib. So the safety profile we can see over here. Yes, the safety profile was slightly worse with the olaparib, but these were mild grade 1 or grade 2 side effects most of the patients, and these were mainly nausea, fatigue, and anemia, which were more with the olaparib. And these were easily manageable. Yes, there was dose reduction, dose interruptions because of the anemia, but later on these were easily manageable. So the next trial was the Paula trial, who had selected all those patients with stage 3, 4 high-grade ovarian cancer, either serous or endometrioid, with surgery upfront or interval debulking surgery, and the patient should have received platinum taxane based chemotherapy, and there should be either no evidence of disease, CR or PR status post chemotherapy. So these patients were randomized into 2:1 fashion with olaparib plus bevacizumab maintenance for 2 years, or placebo for 2 years plus bevacizumab maintenance for 15 months. And the endpoint were PFS, and the secondary endpoint were similar to the Solo 1 trial. So the characteristic of the peculiar point about this trial was that they had taken the representative first-line patient population, because they had included all the patients irrespective of the biomarker status, irrespective of the surgical outcomes, and irrespective of the platinum responses. And they had a pre-planned subgroup analysis according to the tumor BRCA mutation status, HRD status, and HRR mutation status. And it was the only phase 3 trial of a PARP inhibitor with an active standard of care comparator, which was bevacizumab. So we can see over here that the PFS, so the curve separated early on and they remained separated throughout. And this was in the overall population. And we can see over here that there was a delta of PFS of 6 months in favor of olaparib plus bevacizumab, and the hazard ratio was 0.59. So we can see the subgroup analysis over here, that all the subgroup they had benefit with the olaparib. We can also see over here those patients who had debulking surgery with no residual macroscopic disease also had benefit, and those patients who had debulking surgery with residual macroscopic disease, so they also had benefit. So irrespective of the surgical outcomes or the timing of surgery, the benefit was there. So they also looked at the HRD positive status. So we can see over here that 48% of the patients, they were HRD positive, out of which 29% were the tumor BRCA mutation positive, and the rest of them 19% were those with genomic instability score more than equal to 42, excluding tumor BRCA mutation positive status. And 18% had HRD unknown, and 34% had HRD negative status. So we can see over here that the PFS in intention to treat population was, the delta was 5.5 months and the hazard ratio was 0.59. If we see the tumor BRCA mutation positive status or HRD positive, including tumor BRCA mutation positive patients, so it was, so the benefit was persisting, and the PFS was 0.31, hazard ratio was 0.31 and 0.33. But here in HRD negative patients, so the benefit was not there, and the hazard ratio was 0.92. So this was the pre-specified subgroup analysis showing substantial PFS benefit in HRD positive patients. So the median PFS was 37.2 months in the HRD positive status, HRD positive patients, and 17.7 months in the HRD with the placebo arm. Sorry, 1 second. So if we look at the HRD positive patients without tumor BRCA mutation positive, so the median PFS was 28.1 month in the olaparib arm, vis-a-vis 16.6 month in the placebo arm, and the hazard ratio was 0.43. So these patients who were HRD positive, tumor BRCA negative, they also had good amount of advantage with the olaparib. If we see 1 second, please. So if we see those patients who were non-tumor BRCA, so this we have already. 1 second, it is happening. So so this is time to second disease PFS2. So we can see over here that the PFS2 median was 36.5 months in the olaparib arm and 32.6 month in the placebo arm. So it definitely reduced the risk of second progression in intention to treat population. So these were the PFS2 curves. One was in the HRD positive, including tumor BRCA mutation positive status, and we can see over here that the hazard ratio was 0.56. And those patients with HRD positive status, excluding tumor BRCA mutation positivity, so those had a HRD HR of 0.6 in favor of olaparib. And those patients with HRD negative or unknown status, so there was no benefit of adding olaparib to the bevacizumab maintenance. So they also looked at the PFS and PFS2 improvement in HRD positive patients. So the PFS2 was the date of from the date of randomization to the failure on the subsequent therapy. So we can see over here that the PFS in HRD positive population, and they also try to correlate it with the clinical higher risk or lower risk status. So clinical higher risk for those patients who initially were treated with cytoreductive surgery with gross macroscopic disease, and lower risk were rest of the patients. So what they had seen was that the benefit was persistent in both the groups, and the benefit was literally more with the lower risk subset as compared to the higher risk one. And the similar was the curve for PFS2 in HRD positive population. So they also try to look according to the stage of the patient, and stage 3 versus stage 4, the benefit of olaparib was persistent in both in terms of PFS and PFS2. And we can see over here that the time to second subsequent therapy also improved with addition of olaparib to bevacizumab with a hazard ratio of 0.78. If we see the response rates, so the response rates, they were better in olaparib group in the overall population, in the BRCA mutated population, in the HRD positive tumor BRCA positive status, and HRD positive non-BRCA mutation positive status. In all these 4 subgroups, the overall response rate were significantly better with olaparib addition. However, if we see HRD negative patients, so there was no advantage in terms of overall response rates. So all the adverse events, the total number of adverse events, all grade AEs, grade more than equal to 3 AEs, they were comparable in olaparib versus no olaparib group. However, there were more dose interruptions, dose reductions, and the treatment discontinuation in the olaparib arm as compared to placebo arm. But these dose interruption and reduction, most of the times they were easily manageable. So nausea, fatigue, anemia, these were significantly more with the olaparib as compared to no olaparib group. So another concern is regarding the incidence of MDS, AML, and other malignancies. So in the primary analysis and final analysis, so there was not much of difference between the initial and primary and final analysis. And we can see over here that HRQOL parameters were also matched in both the groups. So the key takeaway messages are that HRD SCAR test is a new BRCA test, and SOLO-1 trial has shown that the maintenance olaparib showed 67% reduction in risk of disease progression or death. Paula-1 in HRD positive patients showed a significant improvement in PFS with addition of olaparib to bevacizumab, and there was significant improvement of PFS1 and PFS2 with addition of olaparib to bevacizumab. And HRR and HRD are not interchangeable and should not be considered as substitute for each other in clinical practice for first-line maintenance. With this, I would like to end my talk. Thank you.
Dr. Praveen, thank you. So that was an enlightening talk about HRD and the genomic scoring. I think you have already changed your practice, right? So
yeah,
HRD is the way to go. So how do you see the HRD scores that have been developed in India, and are you convinced with the kind of performance these HRDs they are doing with your patients? So can you share your experience about that?
So I have used the HRD scoring from Strand Life Sciences in 4 of my patients. In fact, 5 of my patients, and 4 out of 5 they came out to be HRD positive. So 2 were germline BRCA mutation positive and 2 were like HRD positive tumor germline BRCA negative. So out of these 4 patients, I have started olaparib in all these 4 patients. So what I have seen is that these patients, so 3 of these patients are in the first line maintenance and 1 patient is in post 2 lines of treatment. So I couldn't assess the response in these 3 patients in the first line maintenance because they are still on this therapy, and since last 4 to 6 months they are on this therapy. So I do not have a long-term data for these 3 patients. But the 4th patient, which was HRD positive, but the tumor BRCA status or tumor BRCA status was not was negative. So that patient was a because in that patient we could have seen the responses with CA-125 or imaging. So because that was a relapse patient, so that patient had response to this. So I'm not sure what is other people experience, but this was one patient who were BRCA negative and HRD positive who had response with olaparib.
Thank you so much, Dr. Praveen. So in the interest of time, I think
I just want to ask one question, if anybody can answer those, because this I couldn't get anywhere. So have anyone experienced that those patients who have germline BRCA mutation, so they have more side effect with PARP inhibitor as compared to those with only tumor BRCA mutation positive status or tumor HRD positive status?
I think Dr. Akhil Kapoor is here. Dr. Akhil, can you take up this question?
Yeah, so now we have experience of treating more than 50 to 70 patients with olaparib or rucaparib. So definitely the toxicities are there, but I don't think this is matching with the presence of a mutation. Definitely we know the efficacy will be different in these patients, but the toxicity per se, in my experience, I have found even when the patient doesn't have mutation, when we use in the 3rd line or 4th line, when other drugs have been exhausted, because olaparib is approved in that setting, we have not found too much of difference in terms of toxicity. The toxicities remain the same. We have learned how to manage the toxicity with experience and time. In my experience, I don't find the toxicity to be different as per the BRCA mutation.
But logically, if we see, so those cells, like if the BRCA mutation is positive only in the tumor cell, so then tumor cell only is using the this HRR defect is there only in tumor cell. If so, then if you are blocking the PARP with PARP inhibitor base excision repair pathway also, so then these will be the cell which will be having synthetic lethality. So if you talk about the germline BRCA mutation positive status, almost all the cells, they will be using BRCA as a way to repair the PARP inhibitor induced double-stranded breaks. So logically, the toxicity should be more with this. I don't know, because I couldn't get any analysis of this sort, whether the toxicity is more in those with germline versus tumor BRCA mutation positive.
So actually, most of the patients where we get tumor BRCA mutation, we actually test for germline, and most of our patients come germline positive itself. So definitely the subgroup of the patient where only tumor BRCA is positive and germline BRCA is negative, it's somewhat smaller actually. As we know, 30% patients where that it is coming as BRCA mutated, 20% will be germline, rest 10% will be only somatic. But in real practice, we are doing more of germline testing actually. We know that might be the confounding factor which limits us this experience.
Thank you.